Okay, good evening, everyone. Today we will start the second webinar about the indication of total knee arthroplasty and the preoperative management too, and a few notes about implant selection for the primary total knee arthroplasty. As you know, first we started with the learning objectives. Who are the patients that are indicated for as a candidate for a total knee replacement, and what are the expectations of them, the relative and absolute contraindication. Also, we will talk about it, and the preoperative care, whether history, examination, planning regarding the X-ray, and some highlights on the implant choices. In the United States, the osteoarthritis has been estimated has an annual cost about $65 billion regarding the work consumption, lost days of work, and the expense of medical treatment and surgical treatment as well. And you can see in this picture, in 2005, they started to know that to estimate the number of total knee arthroplasty in the year 2020, it is about 1 million. And by the year 2015, it is about 6 million. So 6 folds will be increased, as well as in the total hip and revision surgery. Why it is increased? First of all, the osteoarthritis has a population, after the population has been increased in the demography of more than 65 years old age. And this age is an increase the incidence and the prevalence of osteoarthritis. The second thing is that in increasing in BMI, the body mass index, when it is increased also, there will be a correlation of development of osteoarthritis. As in Sharma have suggested that the effect of obesity in relation to the formation of osteoarthritis. The third thing is that the patient's orientation, the early presentation via MRI bone marrow edema, and you see that many patient orientation have suggested that even in minor pain, they are go back to their practitioner or orthopedic surgeon and complain about that. And then they estimated that the early changes of early OH changes have shown an increase in bone marrow edema, which has a correlation with the progression of osteoarthritis. And that's why there is an increase in the number of osteoarthritic patients. No voice. Try to connect the voice, please, Dr. Jamal. Okay. The diagnosis of osteoarthritis now depend on whether it is in joint destruction. Most of the cases are idiopathic. You know that joint destruction due to an osteoarthritis is either idiopathic as a primary, and there are many secondaries like an inflammatory arthritis. Okay, an inflammatory arthritis, and there are some causes of secondary arthritis like the trauma and avascular necrosis and Paget disease, hemophilia, and so on, or a tibia vara congenital anomaly. Apart from the etiology of osteoarthritis, the mechanical axis of the lower limb will shift medially or laterally. That will increase the shear force of the respective compartment and will cause an osteoarthritis of that compartment, as is shown by Sharma again in 2001. We all know about the pathophysiology of osteoarthritis, as the etiology is multifactorial, but the pathology is well confined. either an injury or a degenerative disorder will cause a decrease in the collagen matrix efficacy, and this will causing a swelling of the proteoglycan and lose its stiffness to bear the force, but especially the force that is compressive on the articular surface. This will cause a more water molecules passes into the matrix and will cause it less stiff. The subchondral microfracture will aid the destruction and cause a solid matrix destruction, which is seen here by Cole, which admitted in this article. So what about the decisions? Okay. What about the decisions? Total knee arthroplasty is arguably one of the most successful surgeries, and in terms of reducing the pain and alleviate the suffering of the patient from every case that is destructive joint occur. But this agreement, although it is a very successful during orthopedic reconstructive surgeon, many has been shown it is not agreed to do that, especially the family practitioner, rheumatologist, and orthopedic surgeon that who do not do the reconstructive surgery, as this is suggested from 2007 in this article that is agreed or not agreed to do the arthroplasty of the knee itself. So due to the lack of algorithm that is delineate the TKR indication with a variable knee disorders, and that's why some of the surgeon have to reinforce the patient for non-operative treatment, especially those who are elderly and debilitating disease. However, non-operative treatment must be managed in all patients. Every patient who have an arthritic pain, you have got a trial of non-operative treatment, which is warranted in almost all cases. The total knee must be advised for a patient who have lost the pain and lost the non-operative treatment improvement or benefits, especially when the pain and disability will cause decrease in the lifespan of the knee joint and the current this is ready this back. A trial of non-operative treatment is warranted in almost all cases with the patient presenting with evaluating the arthritic knee. The second thing is that when you have a desirable for a delay surgery, you start with non-operative treatment, as we said. Although innovation of the total knee implants are present to reduce the reoperation and reduce the wear, but it is wise to delay the surgery. The responsibility now is of the reconstructive surgeon is to confirm physical examination, imaging studies who are amenable for the surgical treatment. Remember that the endpoint of pathology of the osteoarthritis, inflammatory, post-traumatic, is that the knee joint cartilage destruction with the pain and dysfunction will end by a devastating pain. The patient quality of life may be affected, and the pain that is not treated with non-operative measures, you have to give the patient as a relative risk and benefits of surgery in each. Remember that the age above 55, it is one of the most important things, that the young age have a risk of revision, although some of patients with younger age, they have some devastating inflammatory disorders like that of the rheumatoid arthritis. The second thing is that the elderly patients have a risk of comorbid disease that cause and affect the post-operative expectations. Failure to respond of non-operative measures is in regards of pain and instability, as we said, is a cardinal indication of the procedure. And non-operative management does not replace the cartilage damage or replace it, the cartilage damage, and neither reverse the disease process. These are the formerly mentioned in many articles and review of literatures that are the relative contraindication and absolute contraindication in total knee. The age below 55 is relative because that new implants comparable results in older cohort study, they suggested it is indicated when there is a severe joint destruction with deformity. In adolescent, that is indicated in a debilitating polyarthropathy, yet the least has been done by Parvizi et al., which presented as a case of total knee replacement in 15 years old. A workman's consumption, it is worse outcome than the match cohort by Mont. Also, obesity, which is an increase in perioperative complication, but the long-term results are comparable to non-obese patients, and many article reviewed that. Post-traumatic arthritis have higher infection rate in the form if there is an open reduction and internal fixation. Also, the extensor mechanism deficiency is causing instability of total knee, extensor lag reconstruction, neuropathy too, again by Parvizi have a higher failure rate and technically challenging in some cases of more than 500 cases of poliomyelitis that have a significant up to 55% of successful rate, but it's technically challenging. New techniques have been developed to reduce this complication. And history of a prior infection, which must be excluded first before starting the total knee. So the absolute contraindication when there is an active infection, inability to tolerate the procedure, and inability to comply post-operative care. And a preoperative assessment, this is this picture from Campbell, according to the knee, objective knee score, satisfaction score, expectation, and functional activity. You have to inform your patient of each one because many patients, especially in expectation, they are expecting to run and to sit on the ground, which is very, very difficult. You can do some sort of flexion in a high flexed design, or there is a newer technique in the resecting the posterior condyle of the femur. That is to say that we will discuss it later in the principle of techniques. So what we could do in preoperative patient evaluation, you have to distinguish the knee joint, distinguish the knee pain from the referred pain of vascular claudication. You have to ask about the onset, the duration, any disability or cannot move, a popping and locking symptoms, medical illnesses and medications with their allergy must be confined, and rheumatoid arthritis, diabetes, obesity, UTI, steroid, those are common risk factor for the infection post-operatively. Medication like non-steroidal, glucose controlling, and methotrexate and you have to consult your colleague medical internal medicine in order to stop the insulin one day before, or hypoglycemic agents, methotrexate must be discontinued, and so on. And we discussed that previously. In the physical examination, you have to see the posture and gait using a cane, like an altalgic knee, arthritis, varus thrust, like an ligament instability. The skin analysis, when you have to look for the sinus, scarring, redness of any lesions, like a psoriasis, swelling, edema, vasculitis, as we said, the psoriasis lesion, and deformity, varus valgus, and flexion contracture must be documented, and so on. And remember that you have to examine the hip and the spine as well. So regarding the radiographic examination and what to do in the radiographic assessment, it's very crucial that when you take an X-ray, you have to think about this. First of all, you know that the X-ray of the knee must have an AP, lateral, and long film standing like this one. So the assessment of the hip, ankle, knee, and the axis to determine the distal cut, and we will see how. Deformities must be evaluated first for the offset in the lateral view and defining the deformity, which is predicting its correctability, or if it is extra-articular deformity, as in post-traumatic tibia vara, developmental, and to identify the site of deformity and calculate whether the contribution of that joint. Again, a bone loss or defect, which may be demand augments, cones, and metal blocks. Evaluation that is needed for special exposure, like for example in patella baja, which required a quadriceps snip, or tibial tubercle osteotomy in order to maintain the integrity of the patellar tendon. A variation in the femoral neck shaft angle and femoral bowing, and previously performed total hip arthroplasty must maybe affect the valgus cut of the femur. Now, what we can do, welcome. First of all, this is the AP view standing long film, and this line is the anatomical axis of the femur, and this line is the anatomic axis of the tibia. And then you start from the center of the hip to the center of the knee. This is the mechanical axis, which is about 6 degrees. The mechanical axis of the tibia is the same one of the anatomic axis, and you can do the tibial cut, which is the yellow line, is perpendicular. And as we said in the previous picture, it is not very much perpendicular because the MPTA, the medial proximal tibial angle, is 87. And then you can draw a line, the green line, perpendicular to the mechanical axis of the femur, which is the femoral cut. And it is 6 degrees, it will be in the valgus cut. Why it happened 6? Because that the normal anatomical tibia, as we said, it is 3 degree varus surface. The 9 degree, the distance between the valgus of the femur, will affect now the effective joint line in 6 degree valgus. So that's why when we are putting our reamer of the femur, it is on 6 degree valgus, plus minus 2. The second step is that when you have a deformity and how to correct it. In a severe deformity, you can correct it either from the total knee arthroplasty cuts or using an osteotomy here, or if you can do augments to verify and to augment the part of the defect of the medial side especially. Don't forget about the tenting osteophyte, either medial and posterior. You have to resect these during the approach, and we will have it later. Extra-articular deformity. If there is an extra-articular deformity, you start it first before you tackle on the total knee arthroplasty using the Cora angle and the bisector lines. And it was a very nice and interesting AO trauma course done by Dr. Ahmed Sabih and Dr. Walid, which has in which it has been discussed very in detail, a very nice detail about the extra-articular deformities. Now you can see these pictures, the area planned in the resection for the standard total knee arthroplasty between two red lines, the area planned in the resected node A. Note that here, and this is the resection of the femur, this is the distal part, and how we can apply this line. First of all, it must be below the medial and lateral condyles. And the second thing is that you have to cut the distal femur while the lateral surface is less than the medial one in order to make it perpendicular. But how much is that? This is depends intraoperatively. Same thing is in the tibia. The tibial tray must be preserved, not much distracted, more distally, no more proximally, but you start from here, from the lower part of the medial plateau. And the third step is that to, like that of the femur, we can here apply the size of the femoral component. So avoid oversizing, not over the lateral or the medial epicondyles, and you can see the posterior part of the femoral component is in line with the supracondylar ridges. The other thing is that in the lateral view, you can see the anterior chamfer. It is almost parallel with that of the anterior femoral cortex. In order, if it is less than that, it will be notching. More than that, it will not contact. And also, you can see here, the size of the femur from the anteroposterior size, which is no more than this one, and the cut of the femur will be here as is shown in the figure. The posterior cortex here will be cutted from this way, and it is easily to be seen intraoperatively in the next lectures. Same as in the tibial tray, after you put the center of the tibia, and then after you determine the cuts, which is perpendicular to the mechanical axis of the tibia, the medial and lateral tray of the tibia must be parallel to that of your cut. Do not, you always do not do any Sorry for interruption. Okay. Okay. Always do not overhang the tibia. And here in the lateral, you can see how to estimate the posterior slope angle. So regarding the last thing is that the implant selection. First of all, there is no consensus regarding a preferable implant in the knee joint, actually. And over several past decades, despite there is multiple design philosophies has been available for any surgeon. There are debatable thoughts about cruciate retaining and posterior stabilizing, fixed bearing device and mobile bearing device. And we will see how. What are the implants? Let's see, overlook and highlight about non-constrained, like the cruciate retaining. This far on the right side, it is a cruciate returning, which preserve the PCL. Hemi-constraint in the left side, which is the posterior stabilizing, and we saw that in the previous lecture, which has compensated the PCL by this post and cam on the femur. A constraint like condylar constrained knee, a rotating hinge, and fixed hinge, and we will discuss it earlier. You can see that the condylar constrained knee has a larger post in the polyethylene that compensates the MCL and LCL when they are deficient. The rotating hinge and fixed hinge, we will discuss it now. Improvement in the quality and performance of the design. It has been subjected to many factors and many factories in the design philosophy. The cruciate returning. The cruciate returning means that we preserve the PCL. This knee design provided the patient with a better motion and compared to the early total condylar knee. The polyethylene in this implant is a thin and the flat on a flat design on the patella. So that's why a thinner liner and the metal back patella may lead to polyethylene failure in the early generation of the CR. So recent design have shown similar survival rate between CR and PS as well. Surfacing on the resurfacing of the joint that sounds unappealing. The bone will be less cut in the CR incomparable to the PS. And the load will be transferred in central of the ligament structure rather than the mechanical one. The natural femoral rollback will be recreated again because of preserving the PCL. And the load, as we said, is transmitted here. In a cruciate returning, the multiple comparative studies have been shown no differences in the functional outcome score and the survivorship between two implants. As it is suggested here, the better proprioception of the CR knees, especially in the sitting position and climbing the stairs. The surgical technique of balancing this PCL are essential prerequisites in protection of PCL from intraoperative inadvertent damage. However, the meta-analysis in 2005 here, it shows that the PS is more in 8 to 10 degrees of a flexion range of motion of the knee. Because of that, they are comparing these results, both of the range of motion. Regarding the CR, it is about 115, and the PS, it is about 135. This range of motion have chosen by the surgeon to go forward to the PS. But in the long term, they will be the same. Compared to proprioception, this is regarding the range of motion. Comparing the proprioception and balance before the total knee, randomized control studies have been shown that both proprioception and balance are the same in the final outcome. Regarding the posterior stabilizing total knee, there are indications. First of all, the severe deformity, which is more than 20 degrees in varus or valgus, inflammatory arthritis, patellectomy, and if there is an altered geometry like a previous fracture or osteotomy, and the PCL when it is the indeficient knee. The contraindication only when there is collateral damage, like collateral LCL and MCL, and they are indicated for the CCK. Posterior stabilizing knee has to remove the PCL and relies on a more conforming articular surface. The potential advantage here include more predictable restoration of the knee kinematics. As the polyethylene of the tibia you see here in the post and femoral cam provides the restraint against the posterior translation of the tibia on the femoral proper rollback. So it has a potential advantages. First of all is that more predictable restoration of knee kinematics, improvement of range of motion, reduce polyethylene wear because more congruent articular surface and more conformity, easy of correction in severe deformity, and easier ligament balancing. And we can add also easier to obtain the proximal tibia. While there are risks of dislocation with flexion instability and tibia, post and femoral cam impingement sometimes, which create a polyethylene wear in the long term after 15 to 20 years, a patellofemoral problems, which is more common in PS, like a patellar clunk syndrome, and increased bone resection of the distal femur, which are concerns of the PS now. Regarding the technique, as we said, the concept here, it's both deformities must be in a preoperative correction of deformities. The CR requires an optimal balancing of the PCL tension. So that's why the PS offers easier coronal deformity correction, especially when it is combined with fixation deformity, which is the latter reminds us to require a distal femoral cut more. But in CR, you don't have to cut the distal femur because of the PCL integrity. The joint line restoration is a mandatory in CR knee. So both have perfect balancing in flexion and extension gap. Remember that in PS, when we are cutting the flexion and extension gap, this will increase by 1 to 1.3 millimeter. As a result, the PS will provide a straightforward gap balance, improve access of the posterior knee that increase the flexion arc of motion, and better exposure of the proximal tibia. Few notes about other designs like mobile. John and Sal have suggested and proposed that low stress articulation and free rotation. The mobile bearing knee were designed to reduce loosening and wear. Many have suggested that, and we see from the first lecture, there is a stress raised between the bone and implant interface. So Dow Noyles have suggested a high stress on the implant bone interface is reduced by allowing rotation of the polyethylene on the tibial tray. This permits more conformity of the femoral implant with the polyethylene, like what you see in the below picture, that increase a stress area and reduce the contact stress. When the area is enlarged, the contact stress will be reduced. In a formerly fixed bearing design, from the femoral side, it is improving the original curvature, a press fit, and so on, in order to not make the cement in the central implantation hole. In the tibia, they are using a cobalt chromium, a metal back support, and the thickness of a polyethylene, which is very low. And that's why an excessive rigidity of a cobalt chromium increase the necessity to undercorrect the knee, and insufficient thickness of the polyethylene is also cause a failure, early failure. So other designs like that, and there are other designs in a bilateral or bicrochate returning is historical design and carries a very high technical difficulty. Thank you for your listening, and I'm sorry for many interruptions, and thank you very much. If you have any questions, I'm ready. Okay, Dr. Ayman, if I may comment, the knee replacement is not a procedure to be considered in a young patient, never in an adolescent. Yes, sir. many have suggested that the adolescent is a contraindication or below 55. We are talking about a severely arthritic joint that cause a deformity. You can refer to the article by Parvizi, and he is suggested that in a very devastating with severe varus or valgus deformity, he had some patients, I think it's up to 100 or 150. I'm with you, actually. It is not a procedure for adolescent, yes. Not below than 45, I think. Thank you, Dr. Ahmed. Well, Dr. Hussein Al-Zorfi, muscle atrophy is considered a contraindication or not? It is a relative. Again, Parvizi have demonstrated two theses about that, and especially the poliomyelitis, not only muscle atrophy, especially if there is an extensor mechanism loss, which is the most important and most difficult one. It is not absolute. Dr. Ahmed Hussein, what about the skyline view and assessment preoperative? Yeah, I didn't mention that actually in the writing, but skyline view is very important for the patellofemoral joint, especially when you have a patellofemoral arthrosis. It is important for you to know that the patella, if it is subluxating or not. First, the second is that when there is an articular damage between the patella and femur, especially in the sulcus. So that's why a skyline view, it is important. But do you know that many patients in our society, they are admitting or they are consulting the surgeon with a late disease process that you cannot more than 45 degree or more than 90 degree of flexion. So it is very difficult. Whenever it is amenable for the patient, you can do it. Dr. Muhammad Qahtan, I think that in adolescent with JRA is done. Yes, I will show you. I don't think I have it. It is. I will send it to you, Dr. Muhammad Qahtan, and who is asking about the young adolescent. I think Dr. Ayman, the article of Parvizi, who has suggested it is very effective in severely damaged knee in arthritis in adolescent. Yes, very important. Thank you. Dr. Zahar Ali, what about intra-articular operation complications? Well, sir, we are talking now of intraoperative. We are not talking about operative technique. And we will start in the next lecture and the next webinar. We have to do the operative technique approaches first, and there are perils of each technique in the saw, using the saw, when you are putting your stamen pin, the stem, the Homan retractor, I call it a Homan retractor, okay? And usually the intraoperative complication, how to avoid it, it is a special entity, okay? So we will talk about this later. Thank you, sir. Dr. Vahar, i.e. patella tendon rupture, partial or complete. This is a special entity of total knee replacement in extensor mechanism loss, what you do and what you have to protect it, okay? And I didn't mention that because it's a very long story. And I put it in, if you see the first of the lecture, you can see every part, there will be a webinar about it. Thank you very much. Do you suggest patella resurfacing in patellofemoral arthritis? Dr. Loay is asking about that. This is a very nice question. Patella resurfacing, actually, there is a dilemma also. And one of the most important lectures in webinar, it will be about controversies in total knee. One of the controversy is to resurface versus to leave the patella. Actually, if we leave it, we do only the what is called the diathermy around the surround denervation. It is not yet has been documented now, but it is effective in reducing the patellofemoral pain. This is first. The second thing is that when you have got a patella with a small size or patella alta, many articles suggested that you can do resurfacing in order to maintain the patella within the normal tracking. And there are many causes what you do it or not. Actually, I do not do it. Wait, thank you. Dr. Ahmed Hussein, what benefit using supine AP view in total knee during planning of surgery? Well, Dr. Ahmed, I myself do not do a supine total knee supine X-ray in planning for the total knee. I usually ask for a standing view because supine there will be loss of the weight-bearing zone, and especially when you have in the lateral valgus or varus stress like that. If you cannot do, you can do varus or valgus stress. I don't do it. I have a question there. Yes, Dr. Ahmed Latif. I wish that Dr. Ahmed Latif will ask your question. What else? Dr. Ahmed, do you suggest TKR for patellofemoral arthrosis with normal tibiofemoral joint or other option? Sorry, Dr. Ahmed, I will let you in. دكتور أحمد لطيف تسمعني؟ دكتور
السلام
أحمد.
عليكم.
عليكم السلام. هلا عمي، شلونك؟
شلونك دكتور سلام؟ شلون صحتك؟
حبيبي الغالي، هلا بيك.
شكرا على المحاضرة الحلوة الجميلة الرائعة.
Thank you very much.
العفو، تعقيبا على سؤال أحد الزملاء. اكو عدة بحوث تتكلم عن الباتيلوبلاستي versus resurfacing.
Yeah.
يعني at the end result most of the articles يعني اللي تقول there is no يعني actual differences between patelloplasty versus resurfacing. قسم support resurfacing، قسم they do patelloplasty with circumferential denervation. أنا سؤالي صراحة when you mention the types of the implant and design, you didn't mention other types. They are used actually by Indian surgeons.
Yeah.
They called all polytibia. All polytibia.
Yes.
So what's your information about all polytibia?
Well, هو الميتال باك هو عادة اللي هو newly advent. But there are all polyethylene. They have shown that they are decreasing the stress on the bone implant interface. But however, there are many suggested articles that shown the metal back has longevity more than the all polyethylene.
You are right.
Yeah.
And I think it's much cheaper than
yes, it's much cheaper, but it is not longer. Sorry.
Because of wearing. Because of wearing of the polyethylene,
yeah.
of the because it's one piece, the polyethylene and the tibia in one piece.
Yes, sir. Yes, sir.
Thank you so much.
Thank you. Thank you very much. I think Dr. Mahmoud Shahab is here also. دكتور محمود، يمكن انت مدى تسمعنا، احنا مدى نسمعك، انت تسمعني زين لانه هسه انا سويت لك انا ميوت. لا استاذ ماكو صوت. اتمنى انه يجي صوتك. بما دكتور محمود يحضر الصوت، دكتور احمد he suggests, do you suggest the TKR for patellofemoral arthritis in normal tibiofemoral joint or other option? Well, I don't think so, because there are stress risers will be affected the patellofemoral joint, and okay, Dr. Mahmoud Shahab. and I used to do a debridement arthroscopically, and this will be in another lecture, which is the the surgical non-arthrotic changes, non-replacement surgeries. أسمعك أستاذ محمود، تسمعني؟ أول شيء حط unmute أستاذ إذا تحب. اي سوي unmute.
unmute. اي
اي هسه اوكي الصوت واضح كلش.
بتسمعني؟
يس سير loud and clear.
اوكي. انا حقيقه بس ردت شويه تداخلات في الاسئله اذا امكن، اذا تنطي لي مجال
يا ريت
يعني حتى نشارك ويا الاخوان ولا هذا. انا اشكرك على هاي المحاضره انه بدها تدخل بين البيزك وبين التايب اوف امبلانت. ويعني you raise one of the important subjects between CR and PS. actually احنا بالعراق يعني احنا بوقتها جبنا 1250 اكو ويانا اجانب، لو اقدر احكي عربي.
يا تقدر تحكي عربي استاذ. هو احنا عندنا بين اليمن الشقيق وسوريا اتصور هيك.
يعني قصدي ماكو اجانب بالانجليزي ولا اي، بس اريد يعرفون الشباب ان احنا جبنا 1250 امبلانت سي ار. كنا قلنا بلكي الاطباء قسم يشتغلون، لكن اللي صار انه كلهم صاروا بي اس سيرجن. السي ار بدلناها بالبي اس، فراح بس اللي اماكن معينه انا ادري البصره اشتغلوا واحنا في مدينه الطب. السي ار ليش ما اشتغلنا؟ لانه المرضى اللي يجون ليت ستيج. Late stage, what does mean? That the posterior cruciate ligament is one of the factors of causing the deformity. So it is the beyond the situation that it caused that it needed instability. When the PS posterior cruciate become the cause of the deformity, so you must go to the PS to cut it and then balance it. That's why it doesn't work CR. Actually, CR is a simple and one step less than PS, and you just 3 steps and you put the polyethylene and everything is in. But it's indication that when the PS is present and it is something in moderate osteoarthritis. This is fair. Secondly, واحد من الاخوان قال بالصغار يعني adolescents. أنا أقول شيء واحد. It is according to the situation, according to the indication. يعني if severe rheumatoid arthritis and came to you on 20 years or 21, what you are waiting? She's suffering from severe painful and arthritis, and the bone is bone-to-bone attachment. So go to the surgery and do the surgery. It doesn't matter. We have patients. We did bilateral knee, and my colleague do bilateral hip for rheumatoid arthritis.
Rheumatoid patients, yes. I remember that.
This is, yes, according to the indication. Sometimes it's post-traumatic. Young has trauma and severe stiffness, severe arthritis. So post-traumatic arthritis, you are waiting for what? For 40, 45 years. No, go to the surgery and total knee replacement and follow it accordingly. This is fair. Secondly, for the young age, there is another indication for unicondylar when there is mild anterior tibial arthritis. So you can do unicondylar. If it is advanced more, you go to CR. If advanced more, go to PS. If it is severe deformity, go to the constrained one. So it is according to the indication. And another question for the weakness of the quadriceps, I think. Extensor mechanism is the important one. And you mentioned in the poly by Perwizi, extensor mechanism when deficient, we get recurvatum. This is one of the most severe complications So for these cases, when there is not deficient, when I am saying extensor mechanism, if it is deficient, so the important is to go rotating hinge and for the locking, because you need last 3-degree locking, and this provide you by RHK. If you haven't RHK, you can go to LCCK, but it need at least you use 17 or 20 poly. And I have 3 cases. Actually, I want to be more cases that I can report it and publish it, because actually recurvatum is severe complication, and when you do the surgery, you must balance between extension and flexion gap. What is the failure, and you deal accordingly. Skyline view is important, especially in valgus cases, because sometimes the patella is contracted or dislocated, and this is one of 2 indications for to go to the lateral arthrotomy. Sometimes we are asking, what is the indication of lateral arthrotomy? Because all the problems solved by medial arthrotomy, and you can correct the deformity intra-articular by medial arthrotomy. But what is about lateral arthrotomy when the patella contracted or dislocated laterally? So this is mandatory to lateral arthrotomy. In these cases, skyline is very important. Of course, with addition that when there is arthritis, and for regarding resurfacing and not surfacing, this is philosophy. This is not indication that to do or not. The indication is when there is severe case of rheumatoid arthritis, that is mandatory you change the poly or sometime in revision. But for the older primaries, it is a philosophy. You can do it, you cannot do it. As Dr. Ahmed, my colleague, at the end, they are same. American all doing resurfacing.
Yes.
Yes, in Europe they are not doing. So it is not a rule, this is a philosophy. أنا أشكرك أن أعطيتني هذا المجال.
أشكرك أستاذ. أشكرك أستاذ.
Okay.
Any more questions, please? We don't have questions here. One of
أي
them.
سؤال أدوم خليه يسأله دكتور سنان أي سؤال.
أكو أحد هم يسأل دكتور علاوي, what about post-traumatic stiffness and total knee? This is a very special entity and very interesting. يعني واحد إنه إحنا عندنا I have a question. Yes, Dr. Ahmed Latif. I will follow. One of them has got a periarticular fracture, for example, a distal femur or a proximal tibia, and got an open reduction and internal fixation years back. And now he has removed the implants with a severe deformity of the knee and osteoarthritis. I think that is a very good question.
نجاوب؟
Yes, sir.
طبعا post traumatic stiffness أو يعني ما مسوي knee without TK.
لا بدون TKA. هو احنا يعني نحضره إلى TKA. Yes.
Yes, this is one of the conditions that you can deal with it without any age. In post-traumatic stiffness, the problem is the tissue is contracted, patella baha, and intra-articular arthritis. So, for the stiff knee, there is a special entity, there is a special plan. The problem when you doing the surgery, you cannot flex the knee, So when you start in extension, because if you're not flexion, how you can put the femur, how you can do flexion gap. So start mid-vertical incision, long incision, started in extension. Don't worry about that. The most important is to remove all the contracture or calcification from the quadriceps and under the patella to start with, and osteotomy by nibbler. This is very important.
And sir,
And if you know,
regarding the approach, can we do trochanteric tibial tuberosity osteotomy?
حبيبي دكتور سنان أنا step by step دا أجي
تمام.
صراحة أجي لك. Yes. So just now to release everything from the quadricep or the patellar tendon. There is one method called Tarabishi method. هذا السوري يشتغل بابو ظبي. Tarabishi ايش سوى؟ عنده method له. He put his hand, release, and reached proximal femur. يعني for the release all the contracted stiff tissue. This is his يعني مقص scissor, you put it and your hand you can reach to the proximal femur apart without any effort. Don't worry, there is no vessels, nothing there. So you are aggressive from the release. Come to the lateral gutter below the patella. All the tissue attachment to the lateral condyle, you must release it. It must mandatory to be released. All the osteophyte around the patella, it must be removed. Then, if there is stiffness still, you do a snip, quadricep snip. This is 45, the upper layer of the quadricep tendon, 45 degree. You can hit lateral snip, and this is also gives you some flexion. If these measure fail, you go to tubercular osteotomy. You do it and to the lateral side with the tissue from the about 6 to 8 cm as the length and 1 to 2 as the width, and you can move it laterally. Then the knee will be open to you. So with the stiffness, the approach is the most important point in your plan.
Yes.
Because whenever you do the flexion, you solve 90% from the problem. Then you do with the intra-articular calcification, you doing your cutting, and be aware that the thickness of the patella is important, that it will not causing malrotation. In these cases, you can do resurfacing to get some thin layer of the patella. That's one. Stiff knee is, regarding its approach, is very important, and it takes time more than the surgery.
Yes, sir.
So I concentrate to the approach, and I have videos for the tubercular osteotomy or stiff knee, actually, how we go to step by step, and in the future we can show you for this complication.
Dr. Ahmed Latif, I think you have a question.
Can you help me? السلام عليكم.
عليكم السلام. Hello, Dr.
السلام عليكم أستاذ محمود. تسمعني؟
حبيبي أستاذ أحمد الورد، حبيبي.
أنا صح أستاذ، الله يخليك. شكرا على الإيضاح.
الله يرضى عليك.
الله يخليك. أستاذ محمود، عندي سؤال عفوا بخصوص الفالغاس أوستيوارثرايتس، not the virus, I mean the valgus. وقت سألنا هوفمان بوحدة من المؤتمرات اللي صارت بالمدينة the approach in the valgus osteoarthritis، بما إنه pathology mainly is the lateral contracture. يقول it's better to approach through the lateral parapatellar incision, okay, and arthrotomy. حضرتك البوليسي مالتك يعني you go through the lateral or medial parapatellar and the valgus osteoarthritis of the knee.
أستاذ أحمد. أوكي أستاذ أحمد.
أوكي أسمعك أستاذ.
الفالغس knee even if it is severe، خلي نقول يعني حتى severe. two indication. الباتيلا أنا ليش قلت contracted؟ لو الباتيلا movable، يعني أنت before the surgery شفته it is يعني movable، يعني ده يتحرك يروح medially أو laterally. This can be solved by intra-articular. يعني intra-articular طبعا الاكسترن روتيشن مالتك go to the 7 لأنه lateral atrophy lateral femoral condyle is atrophied. So you must go external rotation 7 that you get minimum from the lateral femoral condyle. طبعا البلايكا همين release. So if it is patella contracted or dislocated, I will go to lateral arthrotomy. Dislocated or contracted, that means if contracted, it's not coming to the medial side. So go to lateral arthrotomy. Otherwise, 95%, even valgus and varus, you can correct it medial by medial arthrotomy. اكو لاميلر سيبريدر استاذ احمد تقدر تستخدمه لان انت بالاكستنشن you are releasing the first يعني you can get idea the valgus in extension or valgus in flexion. If it is in extension, you can do iliotibial band release, anterior and posterior. This is solve the extension gap. Sometimes you go to posterior lateral the capsule. If it is in flexion valgus, first go to the popliteus tendon. Cut it. Popliteus tendon, cut it. If valgus remained, go to LCL, lateral collateral ligament. Also cut it. Because you must at the end balance medial and lateral. It is not the optimum job that extension gap is balanced. When you go to flexion gap, there is tightness. No. Be free, release the popliteus, release the LCL. Then the joint will be opened to you regarding flexion extension. Of course, in this case, you must use constraint. Because if you using LPS, I think you must go to 17. Yes, 17 or 20 poly. And this is something, and stability added for you, especially as lateral, because you release all the balance structure regarding an extension, iliotibial band and posterior lateral capsule, or flexion, popliteus and LCL. يعني really it's all solved by intra-articular or medial arthrotomy. Lateral arthrotomy for this, I do it if it's contracted or dislocated. But be remember يعني lateral arthrotomy لازم تعرف الباتيلا صارت medially فكل
استاذ نسمعك استاذ.
انطفت الكهرباء.
اي نسمعك استاذ.
From you are coming from lateral side. Yes, this is tricks on the valgus knee.
اوكي
شكرا جزيلا استاذ.
لا لا استاذ احمد حبيبي.
شكرا جزيلا تحياتي شكرا.
لا ولا عين.
Okay, do you have more questions, please? Well, sir, I have a question for you about the valgus knee. Is the intramedullary nailing in the femur will be affected when you have a valgus knee or not?
Yes. Regarding
أستاذ محمود يمكن راح الصوت.
the intramedullary ده اسمعك أنا. ده تسمعني اسمع؟
أي هسه ده أسمعك.
ده تسمعني.
Okay.
أي. When you intramedullary angle between which is mechanical axis of the femur.
Yes, sir.
And anatomical line which is passing from the medullary canal of the femur.
Hello. تسمعني أستاذ؟ Hello. Hello. I think Dr. Mahmoud is disconnected his phone. لا والله يا أستاذ محمود.
تسمعني هسه؟
هسه دا أسمعك واضح. Yes. إحنا regarding the intramedullary nailing of the femur in valgus knee.
Yes. What is the trick there? The entry point go to more medially.
Yes.
More medially, that you go to the femur valgus. If you go centrally at that normal one, you hitch the medial cortex.
Yes.
You hit it. So intramedullary guide ما راح يدخل.
تمام.
اللونج. That's why هنا احنا شو بنسوي تريك؟ انا عندي الشورت وان. حتى هاي المشاكل اللي يصير مرات انتراميدلري ما يدخل، يعني حتى مو بالفالجاس.
يس.
مرات التايت فيمورال كانال، شلون تحله المشكله؟
هو استاذ يا اما اكو اكسترا ارتيكولار، يس، هو يا اما انه مقصره، اكو واحد لاخ اكسترا ارتيكولار.
اكسترا ارتيكولار يعني تدري مو كل السيتات موجوده.
اي اكو
واكسترا ارتيكولار مرات يسوي مس ماتشنج بين ميديال اند لاترال كوندايل لما تقصه. فش تسوي؟ انتراميدلري قصه، فخلي يمكم احتياط. وحده قصيره هذه تدخل للميتافيسيس شويه فوق الميتافيسيس، فتحل لك المشكله لما عندك صعوبه بالانتراميدلري. otherwise you shift medially or laterally.
بالضبط. يعني بالنسبه للفالجاس knee you can do the intramedullary angle between mechanical and anatomical axis the same angle اللي هي 6 degrees, but you only shift it into the medial side. You don't reduce it.
No. You go to the according to your plan 3 or 4.
3 or 4.
This is yes, because you got more varus cutting. Because if the femur valgus, this align that the medially will attach first.
Yes.
So you cut from the femur side more, 9, and the lateral side will be less.
In order to have a rectangle, yes. In order to have a rectangle.
So you're going varus cutting more.
Yes. Dr. Ahmed Hazem, he has a question. We can hear you, Dr. Ahmed.
السلام عليكم استاذ، شكرا استاذ لجهودك.
اهلا
استاذ، اخبارك؟
الله يخليكم.
يمتى استاذ we can do first for the bowing tibia or bowing femur, we first start osteotomy before we did total knee replacement? Where the indication need first osteotomy before we do, because sometimes the bowing is too much. Despite we have short road, but we cannot solve the bowing and the mechanical axis. When we can, where's the indication? How much?
استاذ احمد هاي كلش مهم هذا السؤال.
هو extra articular deformity هو
yes, extra articular deformity. It needs to be measured. How much the deformity? Is it for above 20 or 25? The angle of the deformity. This needs extra articular osteotomy first to get alignment, then to do the total knee replacement. You can do both procedure in same session, but it takes a long time from you. It's a very long time from you, and be aware that you must do osteotomy and pass long stem from the tibia of femur, then you put the plate.
Yes, especially in the tibia.
Yes, because you know, if you put the plate, you cannot pass the stem, and you will be in problem.
Yeah.
If you want with long incision, this to reach the diaphysis.
Yes.
So for me, as experience, it's better to do first the osteotomy. Deal it like a simple osteotomy, and you are doing corrective osteotomy. The arthritis, postpone it later on to do total knee replacement. Of course, you are talking about bowing and arthritis.
Yes.
This is your patient.
This is a very important.
Arthritis and bowing.
This is very important إذا كان يعني the mechanical axis is not aligned in the whether the tibia or the femur. So the main objective that you can reach, the main aim we can reach before replacement, before the knee surgery, is that you have a good mechanical axis regarding the shaft. If you have a deformity extra-articular, if the deformity is intra-articular, it can be solved by a total knee arthroplasty.
بالضبط. يعني هو دكتور احمد واحده هاي challenging cases for the orthopedic to do osteotomy prior total knee replacement, or to do osteotomy and prepare everything in the surgery to do osteotomy and total knee replacement at same time. But yes, so as for me, I do it and postpone it, then I will do it. But if it is mandatory and for plan for long surgery, I do it in one session, but it takes long time.
Yes. Okay. Anyone have more questions? Okay, I don't think we have more questions. If you have it, you can write it down here, and you can see that the next webinar will be at Saturday, June 27th at 9 p.m. It's about the approaches, and we talked here in the discussion, is very nice discussion with Dr. Mahmoud Shahab about part of the tricks in the approaches and tricks in the techniques, especially a difficult one, اللي هو valgus knee. Thank you very much, everyone. Thank you, Dr. Mahmoud, for your participation. And I'm very glad to hear you. Dr. Ahmed Hazem has a question. Okay, Dr. Ahmed Hazem, you can now speak. وينك؟ اياتك. دكتور أحمد حازم تسمعني؟
نعم سمعك. العفو أستاذ، أي تعقيب على نفس الموضوع. يعني أنا
تفضل.
العفو أستاذ، إذا أسوي stem session لازم أحوله إلى more constraint, which is not our aim. يعني إذا كان simple arthritis with great bowing، حرامات أني باعتقادي أن أسوي one session وأحط له long growth وأحوله إلى LCCK. وصحيح أستاذ؟ فأعتقد من خطتك الأولى to do plating, we correct, then we do just to maintain the lesser constraint. أستاذ عندك يعني فكرة أخرى؟
أنت ليش constrained تسويها؟ استعمل PS دكتور أحمد.
بس خلي ستيم وياه.
ستيم. أي بس
يعني
لونج ستيم.
يعني
حبيب دكتور أحمد. بس لونج ستيم.
نعم
لا تسوي. استعمل PS. البولي PS.
وتصدقت the longest stem sometimes صح ما نقدر نخلي يعني ما يصير يعني شلون يصير very long sometimes يعني osteotomy maybe mid shaft.
Yes.
يعني همني الميد شافت انا اقدر اوصل الستيم long like 30 or more and we continue on LBS.
200 استعمل 200 دكتور احمد. اقول 200
20
اي اللونج اللي يوصل لل يعني اباف كانكل مو كانه شيش تسوي يعني انتراميدولار نيلينج
تسوي
يعني we can
كانه نيل تسوي
and we can keep it as LBS.
دكتور احمد
دكتور احمد
دكتور احمد I have another point استاذ محمود اذا تسمح لي. When you have a deformity in the mid shaft of the tibia for example and you want to do الستيم رح تختار هذا very long اللي هو 120 ملم. هذا يكون كلش طويل and it has a keel, anterior keel on the stem of the tray, tibial tray. It will aid you to maintain the intramedullary the track of intramedullary track without breaching the cortex.
هو العفو دكتور سينا 145 طوله.
العفو 155
ذاك 155 وانت 45 اوريدي موجود فيصير 200 اي فيصير 200 ف 20 سنتيمتر اعتقد دكتور احمد از انف اي 20 دكتور احمد
يوصل لحد الرج مال التيبيا يس
اي يعني سوبرا ف يو كان كوركت بس دكتور احمد اتس ا تشالنجينج يعني حقيقه لانه فراكشر اي فيعني if you do it it's very good ولا if you plan two stage and this is the another option.
هو صار بيني وبينك I facing a problem like this exactly. I told them to did first osteotomy better for them and to maintain in the future normal LBS. This is my plan for him.
Yes.
That's why
very good very good.
At this point strictly to make sure that I'm do right.
انت اذا وياي دكتور احمد انت لا تخاف كل شيء نسوي بس انا بس اريد وحدك شويه تشجع
لا
أشهدك
أستاذ، أكيد
أشهدك.
أكيد.
حبيبي.
Thank you very much,
دكتور
sir.
احمد
Thank you
الغالي.
very much. How about you support us?
لا
Thank you very much,
not
sir.
at all. Thank you very much.
Thank you, sir.
Okay, thank you, Dr. Ahmed. This is very nice interruption and very, very nice question, I think, yani, and very nice discussion. And I wish that everyone have a case or he is in challenging cases. I need to be shared here every time and everywhere. We can hear it and we can work together.
دكتور سنان، أنا
Yes.
حقيقة أشكرك لأنه هذه يفتح فد مجال كلش حلو نناقش موضوع الني.
إن شاء
It
الله.
is very important. وهواية أكو أطباء حقيقة interested، وهذا فد شيء مفرح. اللي interested in primary واللي عنده experience in primary to the revision اللي هو subject معين. وأيام الجمعة إحنا نتطرق most complicated الانفكشن، وبعدين احتمال نيجي عن ستابيليتي غير مواضيع. فالاطباء اي شيء عندهم خصوصا ايام السبت اسئله والهذه يعني المواضيع خلي يتطرقوا له، وان شاء الله احنا يعني نجاوبها بكل رحابه صدر الاشياء اللي عندنا معلومات عنها وهذا، لانه هذا حقيقه هي تراكميه مال الخبره اللي احنا شايفيها. شايفيها ودا نعرف شنو. الطبيب يعني يريد يشوف دائما. انا اقول لما انت تشتغل بدني دائما اعرف التريكس لما تواجه مشكله how you solve it. كلش مهمه how you solve it. فلهذا ممكن انا شايف شغله معينه مسويها انت هذه تتذكرها تسويها غير واحد. استاذ احمد مثلا هي فمجموعه من الاراء، وهاي الاراء تيجي من خلال الاسئله interactive meeting. interactive التفاعل. فهذه كلش مهمه. اي شيء عندهم خليه يتطرق له واحنا حاضرين.
This Dr. Ahmed Jassam, this is very much important thing he raised. Can the stem apply to LPS femur, but the stem cannot fit in LPS femur system? I don't think the femur, yes. No, the tibia, yes, but the femur, I don't think so.
No. الفيمر لازم constraint بس بالتيبيا تقدر تسويها. الفيمر اذا تريد تخلي خصوصا الدومي الشورت ستيم او ميدل او لونج you must to LTCK this mean constraint. But you can also use LPS poly. Poly you can use it. Yes. شكرا على المعلومة.
شكرا استاذ
محمد.
شكرا.
العفو. اهلا وسهلا. 100.
عاشت الايادي وممنونين جدا، ونلتقي ان شاء الله بالاسبوع القادم. Thank you very much.
Thank you very much.
Thank you very much, sir.